Happy New Year 2024 and greetings, cherished members of the Mighty Imaging Special Interest Group, and a special welcome to all our wonderful colleagues from the AOPT and from all over the APTA. I'm Bruno Steiner. I'm the current president of the Imaging SIG for the APTA's Academy of Orthopedic Physical Therapy. Tonight, we're very fortunate to usher in the new year with some more grist for the mill and some fresh and exciting unpublished PT-directed imaging utilization data conducted by Sanford Health Fargo's Director of Therapy and Rehabilitation and Clinical Researcher, Dr. Scott Brown. He's going to guide us through the previous hard-scrabble efforts to expand PT imaging privileges in the Peace Garden state, and he'll also share his travails and tribulations in winning institutional approval for the updated practices of primary care PT in his professional sphere. This is a great opportunity to ask Scott about surmounting institutional barriers to implementing imaging referral in a state that legislatively approved the limited privileges of radiography referral. He's going to present imaging for PTs past. Now what? The North Dakota experience. We so appreciated this opportunity to benefit from Dr. Brown's insights and experiences in the institutional trenches. And let's see about North Dakota's next steps to secure full imaging privileges as Scott explores the lay of the land in a state where, similarly to Wisconsin, Arizona, and Rhode Island, radiography ordering privileges were accorded. But first, I have to get through a few business items of our Imaging SIG members, for our Imaging SIG members, and review our nation's imaging scorecard before we begin. And if you've heard it all before, well, as any registered musculoskeletal ultrasonologist with an RMSK would say, repetition is the mother of mastery.
I missed the very beginning of the apology.
I'm going to have to mute somebody here. Yeah, if you guys can keep everything muted, that'd be great. And you know I'm an incorrigible, zealous, true believer in PT-administered diagnostic ultrasonography in muscus. And yes, that was a blunt, abrupt, and clumsy segue to shamelessly plug that you should all learn and sign up for the RMSK exam. This includes you, Claudia. All right, here we go. Alrighty then, let's get to a little business. Just to remind you, last month, our revered and tireless advocates Bill Boysenalt and Chuck Hazel dropped by to present their research with their presentation of DPT imaging education. Will graduates be prepared for today and tomorrow's practice? And what a meeting it was. And if you missed it or other meetings, fear not, they are recorded. I promise you these web meetings are a must view if you want to get boned up on the issues facing PT imaging referral privileges. So just navigate to our Imaging Special Interest Group page on the AOPT website, not the APTA website. There are two distinctly different animals to search through, and you'll be hopelessly lost if you try to find us on the APTA site. I know because I used to do that. I want you to scroll down to the very bottom of the page on our page, and you'll find the Imaging SIG membership webinars and click your way to valuable insights from our speakers. As far as upcoming ISIG membership meetings, I'll say it again, we're going to return to our annual in-person Imaging SIG meeting at the APTA Combined Sections Meeting 2024 in Boston. CSM is just around the corner. It's next month. And the roadshow is coming to rumble into the cradle of liberty, so mark it in your calendars. The ISIG will happen, a meeting will happen on Saturday, February 17th from 1:30 to 2:30 p.m. And I'm excited to chat with all of you in person and look forward to seeing you there. I'll be on my soapbox again, and I'm going to reveal our strategy moving forward to winning more states and ultimately tackle and topple the CMS language that really has proven to be an albatross around our necks for too long. And I swear I want to switch out and get our VP of Education, Brian Young, to weigh in and let us know what's on the docket from our offering from the ISIG. Brian?
Thanks, Bruno, and appreciate the handoff here and all the wonderful news that you share with us and your command of the English language. It takes me a minute to keep up with you, but I really appreciate it. And hey, extra point, Bruno, who does this little character look like down here? The little person that's reminded me of one of our esteemed colleagues kind of teaching away. Bill Boysenalt just seemed to be like the person in the little the shadowed person there teaching. So I thought that was kind of interesting to to have that was a feature on the images to download. But I digress.
That looks
Some
great.
education things we have coming up here for the SIG. First of all, CSM Imaging Masterclass. Come and learn from the experts on some areas of imaging, both MSK ultrasound as well as plain films, and also some cardiopulm. So we're branching into other areas because it's all part of the movement system, and there's other areas that we can use imaging. And so on Saturday, bright and early, 8 to 10, Bruno's providing coffee, so be there. He doesn't know that yet, but he's bringing coffee for us all. Come listen to Aaron, Kyle, Alicia Markowski, Danielle Anderson, and Steve Ramsey as they share cases in our masterclass session. We also continue our partnership with AIUM. We've had great interactions the last few years. It started with Chuck Hazel and his work, and we've continued. And up and coming sometime this spring to early summer, we'll get our next one going with Stephen Ramsey for some more cardiopulmonary MSK ultrasound. And for those that are doing MSK ultrasound, if you have interest in presenting something, let me know, and I'll be glad to work with you and get your experiences out there. This is a great venue, not just for PTs, but for many other providers with interest in musculoskeletal ultrasound and in ultrasound imaging, procedural diagnostic in general. So great way to do interdisciplinary work and show what we as PTs are doing in many novel ways out there. And we hit between 100 to 200 attendees with this. So there's usually a very good audience to get this out here. And then finally, we're looking to continue our masterclass in 2025. And so if you have some cases that you want to participate in within the masterclass, reach out to me. My email is here at the bottom of the slide, and I'll be glad to talk with you in the next 2 to 3 weeks about how we can potentially incorporate your cases and you into this venue to share imaging skills to others. That's all I have, Bruno.
Thank you so much, and I will continue mine. And this is a really speaking of the American Institute of Ultrasound Medicine, Scott Brown. You know what I'm thinking. The pelvic health thing. But anyways, we'll talk later. Okay, so anyways, thank you so much to Dr. Brian Young. Okay, on March 13th, we're following through with our colleague, the irrepressible Dr. Lance Mabry, assistant professor from High Point University, North Carolina. He'll be reporting some fresh data from his most recently published observational study, Physical Therapist Awareness of Diagnostic Imaging Referral Jurisdictional Scope of Practice. He has also recently published Physical Therapists Are Routinely Performing the Requisite Skills to Directly Refer for Musculoskeletal Imaging, an observational study. And if you haven't read it yet, I strongly encourage you to lift the rock you're trapped under and get into it. It's a great read and absolutely germane to what we're trying to achieve for our country's public health policy, our patients' well-being, as well as our beloved profession. More guests and more evidence, April 2024. Aaron, Kyle, and Stephen Correa are going to come and present some more utilization data, and I'm really excited about that too. May Tim Flynn will join us, the legend, and more. So if you've got imaging utilization evidence and diagnostic ultrasound muscus evidence, bring it on and be our guest. We'd love to hear and love to talk to you about it and provide some, get your insights. Thanks. Now, a quick shout for high definition diagnostic ultrasound in the hands of the physical therapist as well, which is absolutely near and dear to my heart. Everybody knows that. If you're not, once again, impressed by this gorgeous rectus femoris tear in longitudinal sagittal axis, and you don't think this quick image there and then in your practice setting won't be useful in your clinical deliberations, well, then I'd say you're on the wrong side of history. I am telling you this, diagnostic ultrasound will unleash amazing and unanticipated potential in our profession and for the healthcare consumer. And if you really aren't impressed by that, just beautiful peroneus brevis blown out with this fabulous inflammatory signal of power Doppler, I don't know how to convince you otherwise. It's just gorgeous. Anyways, to drill down on this a little more, I just want to quickly remind everyone of the unique opportunity offered by the gold standard credentialing body Intellios and their registries. who recognize physical therapists' eligibility to their certification. Primarily, we should all be taking advantage of the privilege of sitting for the RMSK Physician Credential for Muscus Imaging, governed by Intellios's Alliance for Physician Certification Advancements, RMSK. Physical therapists continue to prove their mettle in this super difficult board exam and continue to pass in respectable numbers. Bravo to our Muscus pioneers. And by all means, please take advantage of Intellios's POCUS Academy selection of certifications. There's so many relevant offerings that are available to PTs, not just muscus, but cardiac, pulmonary, vascular applications, and so much more. Really exciting stuff, and we are recognized to sit for these certifications. This is such an opportunity. So where are we with imaging referral privileges? I'm going to do this in an abridged, fast way. But I want to let you know that we essentially regard ourselves at the ISIG as your rapid response resource. If you're planning an imaging initiative, don't plan it alone. Ask us for our amazing resources and don't reinvent a faultier wheel. I implore you to contact us as you trailblaze forward in your respective states. Here's the map. So, and this is germane to what we're talking about today. In deep green, these are all states where we have full imaging access privileges, full privileges. Very exciting stuff. In light green, which we're going to explore today, these are states that managed to try legislative initiatives and they got x-rays passed. So we'll see how that works. Another step forward. In gray, we have practice acts that are largely neutral with silent practice acts with effectively no prohibitions. Well, what does that mean? Well, no one's going to stop you from imaging referral. You may have to talk with some radiology practices and centers if they have any questions, but this has been a successful approach for many PTs. And if you don't believe me, check out our November membership meeting with Colorado's Scott Rizak, who showed us how he managed this. It really turns out to be that imaging referral is a bit of a nothing burger, really. So even if the issue seems to generate some real catastrophization and weird deep-seated insecurity in some of our colleagues, you might want to check this really great webcast out. So in red on the map, most alarmingly, these states in red have explicit language against PT-directed imaging, and these are real setbacks. These states are really going to need tough legislative battles to make any gains moving forward. Once again, I'm going to express my concerns about the decision makers who got us to this point, who might be frankly out of step with current realities for the physical therapy profession and education. And plainly speaking, I'm really concerned that they might be inadvertently or purposefully hamstringing our ability to serve the public's interest in the face of physician and nursing shortages. I think we've got a real opportunity to marshal the vastly under-leveraged skill sets of the primary care physical therapists, and I worry that some decision makers may be unwittingly blowing it for their licensees as well as for the public. And I'm going to state unequivocally that I think it's time, the time has come for our deliberative bodies to reflect our professional realities, and we should be paying more attention to this and making appropriate changes and selections in our state board members as we move forward. So in hot pursuit, I'm talking with 7 other states from Silent Practice Acts who want to do legislative initiatives, but they've asked me to keep it on the down low, so I can't really talk about it, but I'm excited to bring the news as it comes and we get some more approvals from state boards and legislative attempts. So military branches, they have no prohibitions to imaging referral, and they have proven the efficacy of PT-directed imaging referral since the 1970s, and this constitutes a super important precedent that needs to be vigorously cited on every occasion. And this is what we ultimately want to reflect in the center of Medicare services and all state law opinions and rulings. There are 3 paths, if you want to distill it down to initiatives to get imaging referral. So 1, you can exercise the lack of prohibition from the Practice Act. Just don't refer a CMS patient. The radiologist will not get paid for imaging in the case of Medicare patients if the PT makes the order, and that's something I want to address in my tenure. 2, there's get a favorable state board ruling using a proper calibrated question, but that requires and the question has to require the state board member to actually focus on Practice Act language. So you really have to prepare this question, almost take a question writing class. You can ask, we have some luminaries that got imaging referral privileges done via this way, but you really have to provide context, a clever question. Just asking someone, a board member or your board members, whether something is in your practice act, you are going to shoot yourself in the foot. So please coordinate with the AOPT imaging SIG. It's not a question of going, is meniscus in the practice act? They're going to look at it line by line in line item manner. If they don't see meniscus in there, they're going to say, no, it's not part of the practice. The question has to be designed in a different way, in a specific way. So please coordinate with us. It can be done. The third way is the legislative initiative. It's the hardest approach. Only 2 out of 6 approaches have resulted in full imaging privileges. So your preparation has to be maximal. You've got to get your game face on, and you have to be able to fend any sort of objection that comes your way, and you better be protected. As I always say, you don't rise to the challenge. You sink to the lowest level of preparation, and of course, luck favors the prepared. So please coordinate. If you're going to go that route, please coordinate with us. We have all kinds of resources that will be invaluable to you. Now, to the main event. I used this slide before, Scott. I really like this because I don't even know this picture is actually in North Dakota.
I think it is.
The funny thing is, I imagined this picture with you, and I realized there's like a little human being in there. And I'm going like, that's Scott looking to the horizon. What to do next? But Dr. Scott Brown graduated from the University of Minnesota with a doctorate of physical therapy in 2007. He became the orthopedic certified specialist in 2011 and sports certified specialist in 2015. He currently serves as the director of therapy and rehabilitation at Sanford Health in Fargo, North Dakota, and continues to treat people with orthopedic diagnoses with an emphasis on spine care and men's health. He assisted in the development of Sanford orthopedic and neurologic physical therapy residency programs and is currently its program director. He's got a special interest in leading and developing innovative healthcare delivery within a large health system. Recent projects include the implementation of rehabilitation pre- and post-prostatectomy for men with prostate cancer and the implementation of physical therapy ordering X-ray in North Dakota. Fascinating stuff. He's married with 4 children and lives in Moorhead, right across the Red River in Minnesota. Maybe we can get Scott to do some more mischief in Minnesota. Please, please welcome Dr. Scott Brown. I'm going to stop my share, Scott, and let you take it away.
Great. Well, thank you for having me. And I mean, how can you not get fired up listening to Bruno talk about PT? So side story, if you're gonna offer up your data, if you have any data on imaging, just be prepared. You'll be invited to present at this meeting, because that's what happened to me. So we got to talking over email, and just an example of Bruno's passion is he called. We were talking over email, but he wanted to talk to me in person, I think. So he just looked up Sanford Health and called what happened to be like a general number. So he got an operator, and the unfortunate person who answered, he said, "I'd like to speak with Dr. Scott Brown." And she looked me up, and the awareness of physical therapists training, and
pick the day you will change. I was going to do it.
And so she said, "Well, he's not a doctor." And he said, oh yes, Dr. Scott Brown, doctor of physical therapy. And he just kind of let her have it, and not a mean way, but it was an example of Bruno's passion. So I am happy to be here to share our story. And it's the classic, I'm standing on the shoulders of giants in North Dakota, and people that helped to get the legislation done. The screen look okay?
You got to switch out the share. You got your presenter mode right there. So you just got to go to display settings. There you go.
How's that look?
You
okay. So here, Bruno had a picture of the Badlands in Western North Dakota. So beautiful area, Teddy Roosevelt National Park, about 6 hours from here. This is where we live, the flattest possible landscape you can get. So this is what it might look like in the fall during harvest. So a lot of farmland here, not much landscape. Let's make sure this is working okay. So there we are, Fargo. I live in Minnesota, right across the border. This is what it might look like today on my drive home. And so actually last weekend, this is a picture from last weekend. We were having high winds and negative temps. So just another day in North Dakota in January. It's about, what is this, an hour and 20 minutes ago, screenshot from my phone, if anybody's curious. Feels like negative 13, just fantastic. So, Aaron.
Just makes me want to go on vacation, honestly.
Yeah. So I'm a big advocate of when CSM is in the South. We need that. This is what we look forward to in Minnesota. We actually do get 4 months of really nice weather. And this is the lake that we go to on the weekends. This is Cotton Lake. First, and maybe the only trivia question for today, but does anybody know how many lakes there are in Minnesota?
I'll bite 1,000.
So it's the land of 10,000 lakes. It's on our license plate, but there's actually 11,842. So, but if you see a Minnesota license plate, it actually says land of 10,000 lakes. So there we go. Just a little more background on me. I feel like this is really important to share. My high school and college mascots are two of the most ferocious mascots, I think probably ever. So I went to Moorhead High School, and our mascot is the Spud. So this is a potato. It may be the only Spud in the country, I'm not sure. And then went on to undergrad and graduate school at the University of Minnesota. This is Goldie Gopher. So like, it's complete sarcasm. They're like the two softest mascots you could ever imagine. As Bruno said, I'm the director of therapy and rehab at Sanford Health. I've worked for Sanford for 16 years now, 13 of them as a full-time clinician, 2 years as a therapy manager, and now in the director role. So I've been enjoying now helping our physical therapists with anything and everything that they could need to work at their fullest potential. Outside of work, this is my crew. They keep my wife and I busy. And I have to say, we started off with 3 girls. They're neat, they're tidy, they play quietly. And then this picture sums it up. This look is he just basically just walks through and destroys everything that they do. So busy during the day and then busy in the evening, keeping this guy under wraps. So that's just a little bit about me. But I want to take the next 30 minutes or so and talk to everyone about kind of North Dakota's experience, both within our state with legislative journey, but also just talk about implementation to a large health system. And I think Aaron had come to Fargo and did some continuing education with our therapists soon after this legislation passed. Also really appreciated his paper on implementing into their health system. It was a lot more complex than I expected it to be. And I think it's good to share, because as we get more and more states that are able to do this, I think if we can share some of these barriers, I think it'll help us smooth things out as we move along. And then lastly, share how we're starting to try to integrate into primary care models for physical therapists, because ultimately our goal is to really advance our profession. So let's just review a little bit of the legislation. And again, as Bruno said, we have privileges for plain film radiograph. And that's all so far in North Dakota. But it was a big win legislatively for us, we felt, and really paved the way. And we'll talk a bit more about that. But Cindy Flom-Meland, who did most of the work here. And so I really want to give her a shout out. For those of you that have listened to some of these presentations in the past, she actually presented soon after the legislation passed in 2021. And so a lot of what I'm about to talk about is because of the work that she did. Beginning in about 2019, we found that one of our North Dakota therapists had a relationship with a legislator who was ready to bring some legislation forward on imaging. And he brought that to the APTA of North Dakota. And so Cindy just hit the pause button on it. And as Bruno spoke to, there's a lot of pre-work that needs to be done before you just throw a bill out on the table and hope that it gets signed. And so over the course of those 1 to 2 years, Cindy did a lot of organizing with our lobbyist and with other organizations in the state, including our licensure board, to make sure that we were all on the same page, that we were really well prepared, had the right language to increase the chances that we were going to have success with this legislation. As we went through that process as the APTA of North Dakota, when I became the most involved was, well, first involved, I should say, is when we found out that, not surprisingly, the North Dakota Medical Association was opposed to our bill. So the original bill was very similar to how Iowa's language was written in their recently passed legislation. So the hope was to get PTs all the different imaging modalities, be able to order all of those. And so the North Dakota Medical Association was opposed, which again wasn't a surprise. And so Cindy and their leader had set up a web meeting to discuss. And so this is where I entered the picture along with 4 or 5 other therapists. We had a few faculty from the PT schools in North Dakota, myself kind of representing leadership in a large health system, and then several other clinicians that were strong in evidence and knowing the evidence and being able to kind of support this legislation. Now, I have to say, there was not a lot of preparation going into this meeting from having references and having a slide deck, because our interpretation was we were about to have a discussion with the opposition about, what are your concerns and what information can we supply, and when can we meet again, sort of deal. It was not that. And so this was our meeting. This was probably 2 years ago. I didn't have the exact date written down, but I believe this was in January of 2021. The legislation went forward in April of 2021. So this was several months before it went to vote. And this is my stock photo of a meeting, and everybody's happy and everybody's working together to come up with the best solution. And I found out very quickly that this was an IC meeting where there was 5 of us PTs and there was about 20 very strongly opinionated surgeons and physicians that were wanted to kind of speak out against our bill. Remembering that at this time we had MRI in the language. And so that came up quite often in our meeting. So I realize as I start to get a little older, my references get older, but hopefully some of you remember Dikembe Mutombo, the great shot blocker from the NBA. So not in my house. This was the kind of attitude of the North Dakota Medical Association for our bill. And Bruno and I have talked a little bit, and I think there's some work being done with a lot of the people on this call of collecting some of these common arguments against PTs ordering imaging. And it's just, they come up again and again and again, the same arguments. And so I wanted to share what the North Dakota Medical Association came up with. So first of all, PTs don't have the same training as they receive in medical school. what about medical findings? So they brought up examples of what if you're doing an image and you find metastases or cancer? What if you find a fracture? What are you going to do if you find out something that's outside of your scope? Like, how are you going to handle that? They were very concerned about that. As we all know, we're direct access providers. Many of us have had that in our Practice Act for decades. We know how to handle getting something out of our scope within our exam and referring on. But again, they brought that up as a major issue. Didn't feel like it was safe for patients to receive excessive imaging, and the concern that PTs would be ordering excessive imaging. And we'll talk a little bit more about that in a minute. And then finally, MRI, especially MRI, they were very concerned about that this costly test would be in the hands of providers that do not have the right training to do this. So very concerned about someone other than providers or APPs having the ability to order something like MRI. The analogy that I'll always remember that one of the surgeons brought up, very concerned about like the novelty bias, like PTs would be so excited to get imaging that they would just be ordering imaging on anything and everything. So the kid in a candy store analogy came up from one of the providers, and they were adamant that, you know, all the PTs in North Dakota, and they all can start ordering MRIs. There's just going to be MRIs like ordered left and right, and how much that's going to cost patients, which is completely inaccurate, as everybody on this call knows. But whether they were true beliefs or just arguments of convenience, probably a combination of both. But that was one thing that really stuck with me, is they just really were adamant about this kid in the candy store argument. And so, you know, part of this is going through that legislative process, and this is something we all know. I mean, you have the balance of understanding and communicating best evidence, which we have, and people like Bruno are organizing, and you can find the data out there. You can find the military data that this is safe and it's effective and it's good for patients. But you're also dealing with the navigation of politics and the navigation of cognitive biases. So the physicians and the surgeons on this call, again, I don't know if they truly believed all these things, or if we rattled off study after study that disproved their points. I'm not sure if that would have mattered. And so that's where that navigating politics comes in. And that's when Bruno talks about it's the hardest route, and that you need to be extremely prepared, not only knowing the evidence, but also knowing what the political landscape is like, and who are your allies, and how is your lobbying. So I learned a lot from just that meeting because I was expecting it to be fairly civil and a good discussion, and it was more about just kind of attacking PTs in general. So this is the bill did pass. Following our meeting with the North Dakota Medical Association, the decision was made with the input from our lobbyist and other leaders, is that we would take MRI off the bill and other imaging modalities. So not ideal, but if you talk to Cindy, who did a lot of the work, it was still a major win for us, just with the feel that we potentially could have got nothing to start with X-ray was a big win. So we were very happy about that. This is a picture of our PT leadership, those in the background that did a lot of the legislative work along with Cindy. And then the man in the center is Governor Doug Burgum. And for those of you that are into politics, he did run for president for a hot minute. So if you watched any debates, they gave him like, out of an hour, he got like 20 seconds of talk time. So there we go. His little claim to fame, North Dakota governor. So here, here's our success. It was a success. It's not the ideal, but it's I think the first step into getting more out of what we can do. So starting on August 1st, 2021, we were allowed to order X-ray for musculoskeletal conditions. And here's our language. The first paragraph speaks to direct access. This has been in our Practice Act for several decades. I did notice Mary Jo Wager is on the call, and she is a legend of North Dakota, a previous president of the North Dakota APTA, and she was doing a lot of her good work with direct access when we got that passed. And so shout out to her as well. Our new language is below, as you see, and that includes plain film radiograph. Also, if you do not have a DPT in our language, you need to complete a board-approved medical imaging training program. And this was just kind of a backdrop to those that didn't have a DPT. And the board-approved training includes the orthopedic section, home study course on imaging, and then also MedBridge's imaging course by Robert Boyle. So it can be done in a few hours. It's not very rigorous training. So most therapists can be covered fairly quickly if they choose to order images. All right, so where I had a lot of interesting experience, more so than the legislative process, is really, okay, now it's passed. Now what do we do? And there's a whole spectrum of experiences, I'd imagine, across the country, just depending on what type of setting PTs are working in, whether it be private practices or small clinics or small health systems versus a large health system like Sanford Health. So kind of the end of the legislation process was the beginning of our implementation process. So I wanted to share a little bit about this, what ended up being a 2-year process, and be interesting to compare some notes with others that have done this. We haven't had a lot of success in North Dakota amongst the health systems getting this implemented. So Sanford is really the first health system to get going with this. And I've been in contact with some other therapy directors in other health systems that just have not really made any progress with administration, which again was a surprise to me. I thought it would be a simpler implementation. What I found out really quickly, well, I'm just going to tell you a little bit about Sanford first, and then we'll get into that. This isn't really about Sanford Health. This is about imaging and implementation of X-ray into a health system. But just to give you a little background of our organization, it is the largest rural health system in the US, meaning we treat the largest population of rural areas. It's spread across 4 states. So Minnesota, South Dakota, North Dakota, and Iowa. And interestingly, our enterprise director, who's also on the call, Melissa Moyer, and I have been on some meetings with some clinics that we have in Iowa that are starting to try to figure out how to implement this into their clinics with their new legislation. So that's been fun to collaborate with other Sanford sites that have this legislation. There's 46 medical centers across those 4 states, 222 clinic sites, 41,000 employees. Just under half of those are in Fargo, at the Fargo site. We have 3 hospitals in Fargo with PT/OT and speech at all, 4 outpatient clinic sites, approximately 75 physical therapists. So it's really my role, and I was a full-time clinician for 13 years, and now kind of flipped that script. I see very few patients, and just because of time constraints in my role. But really, our focus in the therapy leadership is to promote knowledge and skills of our therapists to maximize the patient experience and outcomes. So it's to advocate for our teams within our health system, knowing the impact that physical therapists specifically can have. And really enjoyed that work, but also realized that it's hard work, because as passionate as we are about physical therapy and physical therapists, that's not everyone in a large health system. So my number one, or my first learning was that favorable legislation does not equal enthusiastic administration. And this is not a knock on our leaders at Sanford. We have some excellent leaders, very supportive of therapies overall. I've had a great experience. I wouldn't have been with Sanford for 16 years if I didn't feel like it was a great place for therapists to thrive. But with so many things going on and running a large health system, elevating physical therapists to practice at the top of their scope is not always first thing on the list. And so there were some barriers to navigate through as we went through this process. I took the kindly Brontosaurus approach. If any of you had the chance to read Influence is Your Superpower, the kindly Brontosaurus approach is being kind and empathetic to the person you're trying to influence, but being just annoyingly persistent. And I feel like that's the approach we had to take to get this done, being annoyingly persistent. And so just little book recommendation for y'all out there. All right, so here's our timeline. I did not expect this to take 2 years to get done, but here we are. A few of the key points in this whole process. First of all, we have the legislation passing on August 1st of 2021. That fall, Sanford Fargo took the approach that we were not going to implement this. Much to the disappointment of the director at that time, one of my mentors, Keith Likas, who again was the director, received a message from his direct report executive director that we were not going to implement this. And so that was frustrating on a number of levels, and primarily because he was not a part of any meetings or had a chance to speak to it at all before that decision was made. And thinking about the landscape in North Dakota, a lot of the leaders within a health system are physician leaders. The North Dakota Medical Association was opposed to the legislation, so undoubtedly our physician leaders were aware of some of this coming down the pipeline. And I imagine that's where some of this came from, is that it was just not going to be put into place, at least at that time. So when I was listening to Corey Zimney's presentation a couple months ago, he talked about kind of those moments of truth and the things happening just at the right time. And Iowa had some things going right for them in terms of the lobbyist for the medical association, I think in Iowa. This was a moment of truth for us that happened because Keith had decided to retire that year. And so December 30th of 2021, and I saved the email and I read it the other day. When you're 1 day away from retirement, the boldness of your email can increase when you're addressing some high level executives. And he sent an email before his retirement that thanked them for all the years that they supported him and everything that he had been blessed with doing at Sanford. And then proceeded to kind of tell them how extremely disappointing it was, especially this X-ray change, and kind of giving them just a reality check on like, hey, this is a big deal for physical therapists that you're not hearing us, and you're not even at least giving us a chance to tell you why this is an important thing. And so giving credit to the leaders that got that email, it afforded me the opportunity to have a meeting with our president and vice president of medical operations about a month later. So I took over for Keith on January 1st of 2022. So about 3 weeks into my role, I had the chance to speak with two physicians who, again, are the main decision makers in Fargo. And having a chance to prepare for those meetings, I feel like our evidence is so solid with what we have published and what a lot of people on this call, a lot of the work that you've done. It was very hard for them to say no, to allow us to at least trial this. And so they gave us verbal support once I presented the evidence, and trying to sell it that, you know, this is a rural health system and we have provider shortages now, and it's going to get worse. And we need to utilize things like this legislation, and we need to utilize physical therapists to help fill that gap. And so getting the verbal approval, we went to the executive directors in Fargo and was approved for a structured rollout, which I'll tell you about in a minute. And there's a lot of great things about working for a health system. As those of you that have worked or do work for a large health system, it can move very slowly. And part of it is to get all the right people together to make sure things get done. So it took us several months to get IT coordinated, our compliance department coordinated, our credentialing done. Surprisingly, we got a lot of questions. We had a lot of resistance in meetings from, there's I think a general attitude from people when you bring something up like this, that are their questions like, kind of like the, who do you guys think you are that you can order x-ray now? And it was just surprising at how often we got pushback from not even decision makers, but people in those IT departments and compliance departments and credentialing. So a lot of work needed to be done there too, just kind of getting people up to speed. Finally, by October of 2022, about a year out from when we actually signed the legislation, we were training our first round of PTs to do it in our spine clinic. In November of 2022, our first x-ray was ordered. And we're gathering our data. We still are, but we gathered for about a year to show our administration that it's safe and effective. So now we're at the point where all our outpatient PTs in Fargo are able to order an image, an x-ray. A lot of these slides are what I utilized with our administration to convince that it was safe and effective, and it was good for patients. And another shout out to Aaron Kyle's work. We certainly used the implementation paper him and his colleagues published to be a roadmap of what we used here at Sanford. Our rollout included these 3 phases, and our Fargo Spine Clinic is kind of a unique practice setting. It's a multidisciplinary clinic, and it's made up of PTs, chiropractors, and pain PAs. All of those professionals act in the same role as a primary spine provider. So it's actually a triage clinic. It's not quite a walk-in clinic, but within a day kind of clinic. And so you can either go direct access, or you can go through your family practice doctor or internal med, or sometimes ortho, where those providers will do a standardized evaluation and determine the next step of care for patients with neck and back pain. And so PTs, we have 6 PTs functioning in that role. And so it was a great place to start with x-ray, because again, they're acting more as a primary musculoskeletal provider. The phase was proposed to be about 3 months. It actually took about 5 months just to get enough x-rays to show at least some decent data. So it took us about 5 months to get 10 images, which is not a bad thing, because we know that x-ray is overutilized, especially with non-specific low back and neck pain. Second phase include board certified PTs, which we have about 20 OCS and SCS PTs in our Fargo market. And so rolled it out to them, and then finally into that last phase. Now, in my opinion, if they would have asked my opinion on how we should roll this out, I would have recommended that we roll it right out to everyone. In that negotiation with my administration, it was thought, well, if we can trial it and get some data. So we did agree to do that, and we knew it was going to go well because we know what the data says nationally. So the main questions that we had from our leadership: is it safe? Will it be overutilized? And will insurance reimburse? This is our first 12 months data. We have more now because it's been about 15 months. But in the first 12 months, we had 35 x-rays ordered, low utilization. 35 out of 35 images were deemed appropriate. So some other therapy leaders and myself, using some of the American College of Radiology guidelines, reviewed each one of the x-rays just to make sure it was done appropriately, and they chose it appropriately. All images were reimbursed. We didn't order for any Medicare patients, of course, but all other private payers reimbursed. And as director, we have a dashboard with safety events that any patient complaint or any safety event, such as falls, things like that, will land on a dashboard that I have to address. And over a year, there was no patient complaints. There was no safety events in regard to imaging. So yes, very safe, which we knew it would be. So is it safe for patients in our organization? The military data really supports this. Our small sample size at Sanford also supports this. Very safe. Will it be overutilized? This was North Dakota Medical Association was just all over this. That was one of their key arguments. We have Crowell's data from a sports setting. We also have more of Aaron's data here on how we utilize appropriately and we use it effectively. So what about at Sanford? Again, those 35 x-rays in 12 months, 27 out of those 35 were ordered in our spine clinic where they act as primary musculoskeletal providers. We had approximately 1,500 visits in the spine clinic, and that's a 2% imaging rate. So very in line with what we've seen in previous studies, so not overutilized. The interesting question I did have to answer is why we went through all this work to get this implemented, and why did you as physical therapists only order 35 x-rays? And so a few things, number one, still lacking that Medicare reimbursement. So a lot of our patients that are coming even through our spine clinic are Medicare patients. Even in the spine clinic where we're doing a lot of the triage, they're still coming via referral from family practice or internal med. And those providers are doing an x-ray first, which is probably inappropriate, but they're coming in. So then those patients that were appropriate for an x-ray, they probably already had it. In our other outpatient sites, of course, we see some direct access, but a lot of referral. We had to explain again to administration that x-rays ordered by PTs are usually very appropriate and we don't overutilize. I think there's a little bit of percentage too that it's new for PTs. And so certainly there's some clinician habits and there's probably a small percentage of missed opportunities there where there were patients that could have benefited from an image that didn't. But I think that's probably very minimal. I think it's the other three that are the biggest contributors. And so if you look at published data from St. Luke's University Hospital, their imaging rate with their data suggested 1.2% utilization, and we were at 2%. So I think that, again, we're just a small data set, but it really reflects other data that we have, which is great. And I think this data, again, images being reimbursed, no problem there. So I think this data really sets us up in North Dakota because the goal, and I think Cindy wants to go after MRI and other imaging modality, we'll have our own data set, which will speak to our legislators more, I believe. And it's just picking that right time of when to go after it. So we hope to spread this across the state and just build more data on it, on the x-ray, just to prove that all the other studies are in line with what we're finding. Lastly, I wanted to leave a little time for discussion and questions, but this is kind of, x-ray is not a game changer. And if you talk to our physical therapists, they knew that going in, that x-ray is not going to completely change your practice. But the implications are moving towards becoming that primary musculoskeletal provider or being recognized as somebody that should be in those roles and are probably the most appropriate in those roles to address neuromusculoskeletal conditions. A few things that we're working on in Fargo. First of all, we have the spine clinic, which has been a great project for us. That's been developed over the last several years, work of Keith Likas, the previous director, Tim Beyer, who's the supervisor there. The PTs there are acting as a primary provider. Currently, we have PTs in family medicine, internal medicine, family medicine residency program that are in the department ready to treat musculoskeletal conditions. Also in the ortho walk-in, same situation, ready to treat those conditions. Where we're starting at is the providers are seeing first and then bringing the PT after. Our vision, or we can see once we can show our value and assert that influence, that we would like to be seeing those musculoskeletal complaints first versus seeing the family med provider or the ortho PA if it's appropriate for a PT. And I think we're going to get there. And I think some of that's going to come when payer changes happen as well. It's hard to motivate administration on some of these projects when we're a fee-for-service payer system. And so if payers go more towards value-based payment, we're going to have a lot of sway with that, because we know that seeing a PT first can really save the patient money and save our payers money. So I think we're going to see more of that. Our enterprise director, Mel Moyer, who's on the call, has done some work with our leaders with our payers, that I think this is coming down the pipeline, that eventually the payers are going to recognize like PTs should be in these roles, and we want to see PT first because we want to save money and we want to save the patient money. So these are a few areas that I think these are the game changers for us, not the X-ray, but the X-ray has been a great step in the right direction. So what's next for us? We're going to keep working in those areas, hopefully assert our influence in being able to take that direct access role in the primary settings. When do we go after that MRI and CT and other imaging modalities? Can we achieve that similar language in Iowa or similar to Iowa in North Dakota? And I think we can get there. One thing, obviously we talked about this early on, but diagnostic ultrasound, how do we implement that into practice? So currently what we're doing at Sanford is we implemented a pre and post prostatectomy program where we're using transperineal ultrasound to image the pelvic floor and evaluate pelvic floor function, but also give feedback, visual feedback to patients that are about to go or have undergone prostatectomy. So how do we broaden our practice with real-time ultrasound? We have a paper that we did on implementation of this prostatectomy program that is published online in the Physical Therapy Journal, and that should be in print in the next couple of months. So that's been, again, kind of tying this all together, and how do we take some of these imaging privileges that just kind of crack the surface and then continue to broaden our profession with that win we had with X-ray. If you want to finish off with an Arnold quote, if the work of being great or achieving something special hasn't hurt or cost you anything, or at least made you uncomfortable, then I'm sorry to be the one to tell you, but you're not working hard enough. Schwarzenegger's new book. So it's just like this process has kind of been painful for me, because I am really passionate about advancing physical therapy practice. I know Mary Jo, one of our previous presidents, Cindy, our current president of the APTA, Mel Moyer, who's a Sanford therapy leader. We all want to push this profession forward, and we want to do it yesterday. But like Arnold Schwarzenegger talks about here, it's like when you're getting a muscle stronger, you got to feel the pain to get the growth. And we felt the pain over the last couple of years, but here we are making progress, and we're excited about what we've done, and we're excited about the future. And so I'll leave on that. Thank you for hanging in there with me and let me rave and rant for a while. Happy to stay on. I know it's 6 now, but happy to stay on to discuss for a little bit or answer any questions. So thank you.
Please stay on. Yeah, you have to feel the pain.
Yeah, that's a good Arnold.
I've had a lot of practice because my uncle, actually, he's German, and he actually talks exactly like Arnold Schwarzenegger. So
that's amazing.
Dr. Brown, Scott, thank you. This is, boy, you got granular to the degree I wanted to discuss this. And I'm sure people have questions, but I'd like to open it up if you don't mind.
Yeah.
This, your account of this is what I'm seeing across the board in terms of the prep. I'm wondering, when you first went into that room where you realized that the stakeholders that you were supposed to meet and collaborate with to have a reasonable discussion was actually just seeing a bunch of rivals in an adversarial circumstance, and frankly, a knife fight. Mm-hmm. And I'm wondering, here you have, do you feel like you were all caught like deers in a headlight in that sort of thing, where you actually just well, let's be real, the fear factor of it all, going like, oh my God, this is wasn't what I had intended. Do you feel that it sabotaged your ability to negotiate with them, as opposed to now that you got prepared and you had some experience going into it in your institutional battle where you said, I know what they can come at me with. I'd love you to comment on that. This is such a hard meeting to take when you got people just basically throwing stuff at you.
Yeah, absolutely. And I think knowing what I know now, we would have had something formally put together so that each of those arguments, because it was not a conversation, it was an attack. And again, rightfully so. They're afraid that we're going to take away something from them. So they're opposed to the legislation. They're ready to knock it down with the arguments they have. If we would have had organized information, that would have helped. And if we would have just been in the right mindset, that would have helped us be ready to negotiate. And that was more, it put that more on the clinicians that Cindy invited to be on, and that myself than her, because none of us could have known how hard they were going to come at us. And then it was really quick. It was within 24 hours. They came back and said, we're not gonna support this unless you take MRI off. So the decisions were made really fast. So your point of, did it feel like it stripped away some of your negotiation power? I think it did, because we just didn't have a chance to lay out okay, understanding how you're feeling and what you believe. Now, what do you think of this study? What do you think of this study? What do you think about military PTs? What do you think about shortages for providers? And just have them kind of speak to some of the questions we had. But here's the way I see it. And again, this reference might fall on deaf ears, but in the movie Aaron Brockovich, the good guys bring in a couple extra people when they're at the negotiating table, just so they have more numbers.
Yeah.
It was intimidating to go in of 20 orthopedic, or 20, I shouldn't say orthopedic, 20 surgeons and physicians against 5 PTs. And as we know, a lot of those surgeons are very strongly opinionated and strong personalities. So I think that was let me next time, let's make sure there's 25 PTs on the meeting to the 20 providers.
Well, exactly. And I've been in rooms with a bunch of hemoncs and radiologists where we had to defend musculoskeletal ultrasound used by physical therapists. But I was ready for the battle. I mean, I just knew what I wanted to say, and it was, when you're prepared, you can disarm anything. But now, I've gotten to the point where, Scott, I feel like there's 8 to 10 boilerplate objections that they bring across. And what I've used lately, first of all, I think I love your Brontosaurus book. I think that's really amazing. And there's a lot of really good principles in that. And it's not far off from, frankly, the Harvard negotiation project's difficult questions, difficult conversations, where you have to use that empathy in a tactical manner. As well as hostage negotiators. This is the way to build that mindset and get people on the table. But I like using the following argument, and I'm wondering if this works for you when you're in the room, where somebody tells you, makes these assertions. I said, I clearly understand. Okay, let's say you have the empathy thing. It's like, I clearly understand you have your patient's well-being at heart, and you are really concerned, and you have some objections, and I feel that. And, so what I use is I typically I apologize that we haven't updated you on our profession, because this is exactly what we study. And 2, I appreciate your assertions and your concerns. What's your evidence to back that up, by the way? Did anybody in the room ask, what's their evidence? Because they got none. And secondly, did you actually discuss the ironic, we discussed this in private, so I'm asking this question again. Did you go wait a second, you're cool with us using ionizing radiation, but you're not cool with us using MRI? I mean, was this actually a thought so you're worried about overexposure to radiation? So did any, if I was frightened out of my wits, it's just kind of like a patient going to a doctor. They have all their questions, and all of a sudden they see the white robe and they just go blank. Did you guys go it's kind of crazy. You're letting us order x-rays, but not MRI, which is totally safe. Okay, we're not going to put metal in the field, but whatever.
Yeah. No, we didn't. they did really focus on that MRI, and it's one of those things that, 2020 would have, hindsight would have been perfect to bring up. I think at the time, and I don't want to make it sound like it was, we just sat there and listened to them and didn't have any opposition. I think that the fear was if we went too hard back at them, that we would ruin that relationship. But
Right.
now, knowing what I know, it wasn't really, it wouldn't have mattered. We needed to come back harder. So I think you do that meeting again, we just come back a little harder at them with the way you're approaching it. Like, yeah, tell me more about that. Do you have some evidence? Can we share some of this evidence with you? What about the ionizing radiation? Are you worried about that? Because MRI would actually be less physically harmful to someone. So
Got another-
yeah.
Yeah, I want to basically ask this question. This is important before, people are starting to go to dinner and stuff like this. And I hate to rush this because I really have so many questions. Do you feel that because now that you got privileges, at least in your physical therapist noticed that they're getting treated with a little bit more respect? Do they feel like they're at the adult table right now when they discuss patient care? Have you gotten that feedback at all?
Yeah, and I think in our spine clinic, especially, the providers, the neurosurgeons, the pain PAs that have seen them in action, now that they've seen what therapists can do, I think they've gotten a lot of momentum, and we're starting to get more momentum around our system too. And I think it's unfortunate, but I think we do have to prove our abilities more so than other professionals do. But I think that's the whole thing, right? Like, again, like, X-ray is not a game changer, but it's what the implications are, and people seeing that, oh, you can order X-rays now, like that, you must know what you're doing. On the other hand, it's you reveal a lot of people's thoughts about physical therapists through the process as you're getting pushback from IT and compliance and credentialing. Like, you guys aren't providers. Like, how are we supposed to change this language in our organization's bylaws? Like, I mean, it's just it kind of fired people up. It was very interesting to see that.
Aaron, you got a question for Scott?
I do. Thanks for asking, Scott. Way to go, man. Just way to go. I can only imagine some of the times where you were not super happy about how things were going, and your staff going, "Hey, Scott, I thought we could order X-rays. What's up, man?"
A lot of that, yes.
Right? And you're the face of it, and you're like, "I'm doing everything I can. I'm sorry, hang in there." So way to go. You didn't lose X-ray. Like that could have happened too, right? If you handled those conversations, in a way that could have been a lot worse, or you could have burned some bridges and all that. So way to go. My question is around credentialing. This has, been the bane of my existence for way too long. And it's different probably in every large healthcare system a little bit, but here where I work now in Chicago, it's a barrier. And more or less the process here is identical to physicians. To credential a PT is identical to credential a neurosurgeon, which makes a lot of sense, right? And we're trying to change that. So how was it for you guys? Did your therapist have to go through the same rigmarole that a attending physician would have to go through, or was there like a carve out, a way around that?
Yeah, and that's the perfect way of saying it, Aaron, is that there's kind of a carve out for us. And what's interesting, and Mel's on the call too, in this meeting with one of our Iowa clinics, when they were looking into this process and contacted credentialing told them, "You're not listed as providers, you can't do this." And that's in our same system. And so we're like, well, forward us the email and we'll respond to it and say, "Hey, what do you mean? We just worked with you and we're doing this in Fargo." Yeah. So I think these are the really tricky things that we didn't necessarily know going in. Like Sanford's, I don't know if bylaws is the right word, but we're not listed as providers. So from a credentialing and compliance standpoint, it makes it very tricky. And then they have to have the conversation. Well, are we going to make physical therapist providers according to our, and that's where I think I hear you saying that's kind of where your barrier is. It's like, if we allow x-ray, we have to change this language. And if we change this language, then all of a sudden we're calling physical therapists the same thing as physicians and APPs. And then what are the implications of that? So I think they're a little bit freaked out by that. And I think that's okay to make them uncomfortable.
Well, I wonder if we need to actually tell them that, the way they get away with justifying PAs and NPs is that they say, oh, and this is what we came across in Utah. It says, well, they're advanced practitioners. I was like, excuse me. I mean, so I literally think we just have to change the tone and simply say, we're in advanced practice.
Mm-hmm.
Very much like NPs and PAs, but actually, sorry, we're actually doctorally trained and they're master's trained. No offense, but we have to start doing that and selling it on a. There's an additional soft sell component of this to lay the groundwork. Maybe I digress too much on this sort of thing. And speaking of soft sells, I think people have to actually, physical therapists really need to actually, what I've made every physical therapist conscious of. If I don't see doctor of physical therapy under their name, because when I deal with pharmacy that pays me to do lectures or anything like that, I basically put down, you're not going to pay me a physical therapist wage or what you think a physical therapist wage is. You're going to see Bruno UK Steiner letters. Then underneath, you're explicitly going to see doctor of physical therapy. Any opportunity I have to make them aware that this is a doctoral profession, I go there. And that's, if we do, there are not many people that do that. So once you walk in the room, they're so shocked that we're making these demands. But that's all I got to say. Brian, you got a question? And actually, Melissa had a question as well. I want Melissa to ask this as well, but Brian first and then Melissa.
I think mine's more of a comment here, and Scott, excellent work in getting this going. And the provider thing is the same in Texas. The PT Practice Act is silent. However, because we're not a provider in the radiology technician one, they can only accept referrals for imaging from a provider. And so Texas is actually one of those states that is explicitly states you cannot do it, but it's not from our Practice Act, it's from the others. Nurse practitioners and PAs work under, they don't do independent practice. They work under physicians. And so they're still getting the oversight and that preceptorship, if you will. Even in the military system, when I worked there and oversighted a bunch of clinics, I had to see how that goes and make sure my extenders had physician preceptors. And so, yeah, I like your point about making them uncomfortable and facing this, because the others are doing it under a protected kind of way, but we're autonomous, but yet we're also on the same side of the coin, collaborative in the conversation. So I just wanted to put that in there. And that's what I face too, as I go from military to try to do this in Texas and support Bruno and the other members of the SIG and the great momentums that we have. So I yield the rest of my time to Melissa.
Melissa, go ahead.
Hey, sorry if this is a little loud. I got the snowblower going out here and the neighbor kids peeking in my window, looking at me, wondering why I'm still on the computer. But I'm on the South Dakota board of physical therapy, as well as the enterprise therapy director. So I'm trying to on multiple fronts, trying to push these things through as well too. But my question comes more from the board perspective, trying to push it through in South Dakota. Number one, who called the meeting with the North Dakota Medical Association and the PTs? Was it the legislator that was introducing the bill?
And that's where I'd have to get back to Cindy on it, because I think our lobbyist was hearing that North Dakota Medical Association was opposed, and Cindy asked if they would be open to a meeting. I think that's how it went, but I wasn't a part of that process. Okay. And I can definitely find out for you, Mel. And
in the last session in South Dakota last year, we passed our own board for physical therapy, and we were getting pushback from the South Dakota Medical Association on just our own state physical therapy board. So I imagine we're going to have that as well too when we propose any legislation on imaging. But my next question is also for North Dakota. Do you feel like now that once you have the X-ray data, that you'll be confident that the MRI and the imaging and everything else will go through, or do you wish that you would have never compromised on that in the first place? If you
Well,
had to do it again, or
it's-
in
it's-
South Dakota, should we compromise or should we,
Buyer's remorse.
Yeah,
Yeah.
I'm gonna defer to the rest of the group to answer that because they have much more experience than I do in just the one state. It's easy for me to say because I wasn't the president of the licensure board or the APTA that had to make the calls. Of course, we were surprised that we pulled MRI so fast, like the other people that were on the meeting, because we weren't part of that conversation. It was just decided by our lobbyists and our leaders. But I think they had good reason. And I don't know as much about how the lobbyists function, but that was like the pulse that he got. It's like, this will not pass if it has MRI. And so I don't know, what does everybody else think about trusting their, political contacts? I don't have enough experience with that to know the answer.
So I had a little conversation with a nameless lobbyist that swore up and down they wanted to pass in a certain state, which will remain nameless, and a lobbyist that essentially wanted to talk with payers, or they wanted this approach to legislative. And that's as much as I'm going to give you, his approach was that he was going to consult with the orthopedist to see if they would give us permission to order imaging. I said, this is an adversary. This is a rival. You're going to get no. It's going to be no. As simple as that. Well, I've done this 20 years and I know this is, I'm going like, oh my God. So it's amazing how I really want us to believe in our own abilities and believe that we can actually have agency. And part of my problem is that in general, Scott, is that I think culturally we've given away our agency. And it's now time to just essentially go. We have to learn from all these amazing efforts that have happened, so we can compile them and see what in this great experiment we have to do to move forward. So what you guys did was really make our game plan or just sharpen our game plan. So I don't consider it a defeat. I think we're going to get forward. I think this is what it was. But boy, did it give us a lot of information. I still think next time, just like you were able to move the ball in your institution, my gut says that you'll know how to go to the next knife fight. And I believe your approach to the persistent dinosaur is really amazing. I tend to be, in private, very reactionary. I'm not bad at the negotiating table, but really it takes a lot of kindness, empathy, and persistence. And I think you show that. So I feel like you're going to get there. It is easy for me to criticize Tom Brady for a game, a bad game on a Monday, or whatever. We have no business to. We need to learn from it. We can pontificate, but really, this is the ball this was the pitch you were thrown, and you did something with it. I still think it's a movement forward. That's my take on it. I want everything, though. You know me.
Yes, and I think talking with Cindy, who was the major player in this, they felt it was a huge win, and I believe that. I believe that it was when they first started, it didn't feel like they were going to get anything because of the strength of that.
Yeah.
Can I say real quickly just a couple things? Melissa, it's a great question. I think you look at your neighbor to the north and go, hey, you did it. How do you feel about it? Would you have done it differently? That's a fantastic way to live life. You did something. Would you do it the same way again or not? I feel that if in your conversations you can focus on patient safety, I'm sure, Scott, that's what you did, and everyone else who's gotten x-rays, they probably did the same thing. But if you shifted away from MRIs or CTs or whatever to whatever the patient is going to need to be safe, and you use that language, well, what do they need? Well, sometimes they need x-rays, sometimes they don't need an x-ray at all. They need something else. And so in order to keep the patient safe, we need da 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 da. This is a patient safety issue. And boy, is that loaded language a little bit. It is, but
No, but that's what you got to use.
it gets people's attention when they say, no, you don't need to keep people safe. No one's going to say that, argue me out of how this isn't keeping people safe. So.
You see any use, Scott? You're all are a lot of administrators here and a lot of leaders. This is a jump ball. I see use of a workshop, a language workshop, and a role play workshop where you walk in that you're about to walk into the buzzsaw, and how do you face an objection that basically, some of our leaders faced legislators that can't even believe the fact that we have direct access. It is, you have direct access. Do you see a use for I don't know, an imaging type of or a negotiation workshop or some sort of thing where we really kind of say, okay, these are your objections. What's your answer? Here's your list. Here's how you go about it. You think there's any use for that, Scott?
Yeah, absolutely. I mean, I think just comparing notes on what works, what doesn't work, coming up with those arguments that both administrators are going to have, and also the medical associations and things like that. I mean, I would say yes, absolutely.
Thanks, Scott. Any other questions for Dr. Brown? All right, you've stymied us. Thank you so much. When is this stuff going to be published, man?
Yeah, I'm talking with a couple professors from University of Jamestown here in Fargo who we worked on several projects. So we're gonna get something out there on our data. So it's locked in.
Great. And in terms of the American Institute of Ultrasound Medicine, would you be willing to do some sort of presentation on men's pelvic health?
Absolutely. Yep. And we'll be at CSM.
I think this would be amazing because it's physicians and sonographers that watch this. I mean, this is insane advocacy for us.
Yeah, for sure.
You'd be willing, would you see a part 1, part 2 type of thing, or just a kind of a 1, or what do you think?
Whatever you want.
Okay.
Come up with something.
Well, that's nice. All right. And we want a presentation as well for our purposes as well. It would be really nice if that's cool with you, if you can talk with your people and all that stuff.
Yeah, we can do that.
All right. Dr. Scott Brown, North Dakota. Wow. Pleasure to have you. And thank you for sharing this deeply with us. Aaron, Kyle, Melissa Moyer, and all who joined us. Thank you so much. Alicia Markowski, you're going to be presenting at the CSM along with Aaron, Kyle. That's going to be pretty amazing. And Dr. Brown, you're also presenting?
Yeah, we'll be there, and we're going to do a men's health presentation. So love to meet everybody there somewhere.
I'll show up.
Yeah.
Thank you so much, everyone. Dr. Brown, thank you once again.
Yeah, thanks for having me. Have a good night.
All right, everybody.